Welcome to Roadmap to Residency. Today we are diving into syncope and palpitations, a high-yield topic for Step 2 clinical knowledge. I'm going to walk you through real question stems and show you exactly how to approach these on test day. This is not about memorizing everything. It is about recognizing patterns and applying a systematic approach. Before we start, make sure you have your first aid or your favorite board review resource handy so you can follow along and mark up the key points. Let us get started. Here are our learning objectives for today. By the end of this video, you will be able to master the syncope workup algorithm so you can quickly identify the most appropriate next step. You will learn to differentiate cardiac from non-cardiac syncope using key clinical buzzwords, and you will recognize neurally mediated syncope and orthostatic hypotension patterns in question stems. Remember, the boards love testing your ability to identify the next best step based on clinical clues. Do not forget to like and subscribe, and check out our expert tutors at roadmap2residency.com. Let me show you the framework that will help you crush syncope questions. Step 1 is always the initial evaluation. On the boards, this means history, physical exam, and an electrocardiogram. Here is a test-taking pearl. A detailed history alone can diagnose up to 50% of syncope cases. Look for prodromal symptoms, triggers, patient position, and witness descriptions. The electrocardiogram is required in all patients with syncope. Step 2 is risk stratification. High-risk features mean admit and monitor. These include structural heart disease, abnormal electrocardiogram, exertional syncope, family history of sudden death, and older patients with no prodrome. Low-risk features mean outpatient workup is okay. Think young patient, clear vasovagal trigger, normal exam, and normal electrocardiogram. Now let us talk about the buzzwords that will help you distinguish cardiac from non-cardiac causes. For cardiac syncope, watch for exertional syncope, palpitations right before losing consciousness, family history of sudden cardiac death, and any known structural heart disease. For neurally mediated or vasovagal syncope, the classic setup is prolonged standing, hot environment, emotional trigger, and a prodrome of warmth and nausea. For orthostatic hypotension, the stem will describe syncope upon standing, typically in an elderly patient on multiple medications, with dehydration or autonomic dysfunction. These patterns are your roadmap to the right answer. Let us work through our first case. A 17-year-old male basketball player collapses during practice. He briefly loses consciousness with no prodromal symptoms. His father died suddenly at age 35. On exam, you hear a harsh crescendo-decrescendo murmur at the left sternal border that increases with Valsalva. What is the most likely diagnosis? Take a moment to identify the red flags before looking at the answer choices. Option A is vasovagal syncope. Option B is hypertrophic cardiomyopathy. Option C is aortic stenosis. Option D is dehydration. Option E is panic attack. Let me walk you through this case. First, identify the red flags. Exertional syncope without a prodrome equals cardiac until proven otherwise. A family history of sudden death plus young athlete is the classic setup for hypertrophic cardiomyopathy. The murmur that increases with Valsalva is pathognomonic for hypertrophic cardiomyopathy because Valsalva decreases venous return and worsens the outflow obstruction. Now let us eliminate wrong answers. Option A, vasovagal, is wrong because there was no prodrome like nausea, warmth, or sweating. Vasovagal would not occur during peak exercise. Option C, aortic stenosis, is tempting because it is exertional. However, that murmur radiates to the carotids and typically occurs in older patients with calcification. Options D and E, dehydration and panic attack, do not explain the murmur or family history. The correct answer is B, hypertrophic cardiomyopathy. Review the cardiomyopathy chapter in your resources. Here is case 2. A 72-year-old man with diabetes and hypertension on multiple medications presents after passing out when getting up from bed in the morning. He felt lightheaded immediately before losing consciousness. Supine blood pressure is 140/90. Standing blood pressure after 3 minutes is 100/65. What is the most appropriate next step? Option A is Holter monitor. Option B is tilt table testing. Option C is echocardiogram. Option D is review and adjust medications. Option E is electroencephalogram. Let us break this down. First, confirm the diagnosis. Orthostatic hypertension is defined as a drop in systolic blood pressure of 20 or more millimeters of mercury, or a diastolic drop of 10 or more within 3 minutes of standing. This patient dropped 40 systolic. That is classic orthostatic hypertension. The setting of elderly diabetic and on antihypertensives is textbook. Now apply the algorithm. Options A, B, and C are unnecessary when the diagnosis is clinically evident from the orthostatic vitals alone. Option E, electroencephalogram, is for seizures, which this is clearly not. The most appropriate next step is reviewing and adjusting causative medications. Antihypertensives, alpha blockers, and diuretics are common culprits. The correct answer is D. Check out the autonomic disorders chapter in your board materials for more details. Here are some high-yield pearls on orthostatic hypertension that you should know for boards. The diagnostic criteria are a systolic drop of 20 or more millimeters of mercury, or a diastolic drop of 10 or more within 3 minutes of standing. Measure blood pressure supine, then at 1 minute, and 3 minutes after standing. For management, step 1 is to remove offending medications like alpha blockers, diuretics, and vasodilators. Step 2 is non-pharmacologic measures including increased fluid intake, compression stockings, and teaching the patient to rise slowly. Step 3, if refractory, is to consider midodrine or fludrocortisone. Review the autonomic disorders chapter in your resources for the complete management approach. Case 3. A 23-year-old female medical student passes out in the phlebotomy lab during her first venipuncture attempt. Witnesses report she looked pale and sweaty before slumping to the floor. She regained consciousness within 30 seconds. Her electrocardiogram is normal. What is the most likely diagnosis? Option A is seizure disorder. Option B is vasovagal syncope. Option C is cardiac arrhythmia. Option D is pulmonary embolism. Option E is hypoglycemia. This is a classic neurally mediated or vasovagal syncope presentation. Let us spot the pattern. The triad is trigger plus prodrome plus rapid recovery. The trigger here is a blood draw. Other common triggers include pain, prolonged standing, and emotional stress. The prodrome includes pallor and diaphoresis, which witnesses described. And recovery was rapid, within 30 seconds. Now, why are the other answers wrong? Option A, seizure, is out because there was no tonic-clonic activity and no postictal confusion. Option C, arrhythmia, is unlikely with no palpitations, a normal electrocardiogram, and a clear situational trigger. Option D, pulmonary embolism, does not fit because there are no risk factors and no dyspnea. Option E, hypoglycemia, does not match this situational trigger pattern. The correct answer is B, vasovagal syncope. This is the most common type of syncope and has a benign prognosis. Case 4. A 45-year-old woman presents with recurrent episodes of sudden onset rapid heart pounding followed by near syncope. Episodes last several minutes and terminate abruptly. She has no structural heart disease on prior workup. Her resting electrocardiogram shows a short PR interval with a slurred upstroke of the QRS complex. What is the most appropriate next step? Option A is reassurance only. Option B is beta blocker therapy. Option C is electrophysiology study. Option D is Holter monitor. Option E is cardiac catheterization. Let me walk you through this critical electrocardiogram finding. The short PR interval plus delta wave equals Wolff-Parkinson-White syndrome. The delta wave is the slurred upstroke described in the stem. This represents an accessory pathway that predisposes to reentrant tachycardias. For management of symptomatic Wolff-Parkinson-White with syncope or near syncope, electrophysiology study is warranted for risk stratification and potential ablation. Option A is wrong because syncope is a high-risk feature requiring further workup. Option B, beta blockers, can actually worsen conduction through the accessory pathway during atrial fibrillation, which is dangerous. Option D, Holter monitor, is for intermittent arrhythmias with an unclear diagnosis, but here the diagnosis is evident from the resting electrocardiogram. The correct answer is C, electrophysiology study. Review the arrhythmia chapter in your resources. Here is our final case. A 60-year-old man with a history of prior myocardial infarction presents with his third episode of syncope in 6 months. Episodes occur without warning. His electrocardiogram shows evidence of prior infarction, but no acute changes. Holter monitor was non-diagnostic. Echocardiogram shows an ejection fraction of 30%. What is the most appropriate next step? Option A is tilt table testing. Option B is implantable loop recorder. Option C is electrophysiology study. Option D is carotid ultrasound. Option E is repeat electrocardiogram. This patient has multiple high-risk features for cardiac syncope: prior myocardial infarction, reduced ejection fraction of 30%, syncope without prodrome, and recurrent episodes all strongly suggest ventricular arrhythmia as the cause. When you have structural heart disease plus unexplained syncope, electrophysiology study can induce the arrhythmia and guide management, including possible implantable defibrillator placement. Option A, tilt table testing, is for suspected vasovagal syncope with no structural heart disease. Option B, implantable loop recorder, is reasonable, but electrophysiology study has a higher diagnostic yield in this high-risk scenario. Options D and E will not identify an arrhythmia. The correct answer is C, electrophysiology study. Review the arrhythmia chapter for more on this workup. Thank you so much for watching. If this video helped you, please like and subscribe. And do not forget to visit roadmap2residency.com for expert tutoring and residency advising. Good luck on your boards.